I'm going to talk to you about a workshop that we had in March, and I'm going to tell you some of the outcomes and the things that we found, and I'm going to tell you what we're going to do about it. But I'm going to give you a bit of context before then, if that's okay. But I just wanted to explain why I'm here, what led me here. So, as Lauren said, trained as a pharmacist. I'm still registered as a pharmacist. God help me if I ended up working in practice as a pharmacist, because I really don't think I'm safe anymore, but I still maintain my registration. I spent a lot of time doing prescribing advice in the South Wales valleys. Went into public health purely because I was looking for a job in Cardiff, if I'm honest. And I've been there now for nearly 20 years. Some of you may have had touch points with us around some of the work we're doing with inhalers. There's lots of posters we've got here, and I'll talk about that briefly. And that sort of led me into the kind of what happens after inhalers at this green agenda. Okay, so it sort of started really in about 2018 when the NHS Wales produced a carbon footprint report. We had to look at this is pre-COVID mind, and kind of thought, oh, this is really interesting. It then transpired that this report was only in secondary care. There's no prescribed primary care data that informed this report. But the big thing that jumped out at me as a pharmacist was the chunk of carbon footprint associated to medicines and drugs and what's happening in that space. So as a result of that, there was a number of strategic delivery plans, Welsh Government endorsed policy documents, and the first one in 2021 had a real focus on inhalers and anaesthetic gases, which is why there's been a lot of work done on that. That has been refreshed, and it's actually going much more into the broader medicines management space, although inhalers is still very much important and it is still being measured, but we're looking at the sort of broader aspects of it. So, we talk about inhalers. My colleague Richard, who's sitting at the front here, we won an award, didn't we, Richard, a couple of years ago, which we were delighted and actually quite humbled, for a task and finish group that we set up. So, a strategy was written by AWTTC, it was presented and endorsed by the All Wales Medicine Strategy Group, which was really a route map to how we decarbonise with inhalers. We set up a task and finish group. I had the privilege of chairing that group and a number of the subgroups. And what we claim is not the task and finish group necessarily that caused the change, but it was that combined, coordinated effort. And the graphs that you can see, so the graph that has the orange stripe and the big black line is reported monthly by AWTTC, and that's the drop in carbon burden as a result of the inhalers and the work that has happened out there across Wales. And then the smaller graphs, that might be harder to see, but hopefully the slides will be shared, will show the decrease in what we call high global warming inhalers, which is mainly the MDIs, and an increase in the dry powder inhalers. Now, this all came along at the same time that the All Wales prescribing guidelines came out for asthma, COPD. So again, there's lots of clinical sort of guidance to help this. Quality improvement projects at local level were included in the GP contract. So loads of drivers for change. But for the first time, and I've worked in medicines management for years, as Lauren says, I actually think this is a massive achievement in a very short period of time. I think that's the thing. We're not there yet. We haven't hit the target. The task and finish group has concluded because it's task and finish. We're trying to embed this into business as usual. We might need to resurrect it if we see it going the wrong way. So, it'd be remiss of me if I didn't say this. There's 3 posters there, all about inhalers you might want to look at. Lizzie has authored one, and Harrod has authored the other. And I don't know whether our colleague from Hywel Dda is here. Dave Edwards, are you here? Not sure. There's another one around lessons in asthma, which is a fantastic project going on down in Pembrokeshire, and around going into schools and doing interventions around asthma. So, lots of information on the posters you might want to have a look at. I haven't been involved in any of this. I cannot claim any glory in any space around this, but I thought it's worth noting that there's also been an impact as a result of the anaesthetic gases being identified as hotspots. 2 strategies, different gases, and you can see that the one at the bottom is nitrous oxide, that's coming down, and the other one has come down, but for some reason is a little bit of a blip. So there's lots of work still going on in hospitals around manifolds and decommissioning, etc., etc. Okay, so that's my history. That's the work I've done. I'm lucky I get paid to do this. This is my job. But it did make me think, right, okay, we've done inhalers to death. What what's next? Where do we go with this? And I suppose I was inspired by many people here today, Nuala in particular, because I've done some of the Centre for Sustainability healthcare courses. I've listened to Nuala present at other conferences and things. But particularly, we have a Four Nations collaborative with some colleagues in Scotland, Ireland and England. And Scotland are doing some great work around the kind of broader sustainability in medicine space. They are working with the university, they put a lot of money behind it. And they've come up with this thing called an eco map, which I loved, which they shared. And it made me think, right, okay, so what are we doing in Wales? What's going on? What can we do and learn from our colleagues? 2 individuals, so you didn't know I was going to name you. I know Jamie's probably not here today, but if anybody hasn't listened to Jamie's TED talk about, I think, his prescription to ocean, it's really interesting. So he talks about, medicines and the effect it's having on the environment. I listened to that and thought, gosh, I didn't even know Jamie was interested in this work or he was doing anything. And again, we got Vanessa, who I know is here, and I think is doing a workshop later, who was my voice of reason, who emails me regularly with stuff and goes, have you seen this? Have you seen this? So, there's some really good champions out there without realizing that they're doing it. But it made me think, well, who's talking to each other? Why are we doing it all in isolation? How do we bring this together? I then had a little look, and there's loads of other, and there's many more of these. I started looking and trying to piece things together and think, well, where is the link with medicines? What have we got out there? And there's lots of resources, some quite old now, that for me seem to make that link. And we've got new things going on around only order what you need, etc. So I go back to why I think it's important, and I think there's 4 reasons. We know medicines have got a huge carbon burden. We've got that from the carbon footprint. We know medicines are increasing. The volume of prescribing is going up year on year. So we know that'll probably inevitably cause more waste. We also know that if we get it right and optimize medicines, where it's good patient care, so there's lots of opportunities there. And we also know the harm that's caused to the environment, and that's been touched on today, particularly around the waterways. There's lots of unknowns in this as well, though. We don't know, we can't measure some of this. So we got a group of people together. There's a number of people here today that attended the workshop. Apologies, it was a bit of an invite only because I wanted people that I know had already been working in this space, bringing people together. And we wanted to really test what's the baseline knowledge for this. We wanted to see what was going on, what is happening that key people around the table could tell us. I can't read with those glasses on either. We wanted to work out what needs to be done, and then we wanted to identify priority areas. I think naively, I thought, we'll do this. Nobody asked us to do it. We just thought, let's do it. And then there'd be like a magic solution. There'd be the next inhalers. We'll identify that, and then we'll focus all our efforts on that. That wasn't quite the case. We used what Nuala has already shared with you around the sustainable clinical practice. When I talk about this, I've added 2 extra ones, and I've spoken to the author of this, Francis Mortimer, in the hope that they can adopt it, because I think we also need to talk about adaptation, because that's missing, and also inequalities. You picked up on that. The numbering isn't correct. That's not intentional. That's my error and mistake, anybody that spots that. But basically, I'm not going to go through this in great detail, but I've tried to map this around what does it actually mean around prescribing. And again, some of this has been shared from our colleagues in Scotland. So when we talk about prevention, what are we actually thinking before we reach for that prescription? What could it be like? What does patient care mean around medicines? What does the lean service delivery look like, and what are low carbon alternatives? And there are some examples there, but for the essence of time, I'm not going to go through them. The slides will be shared. Okay, these were the key themes that came out of the workshop. And the first one was around raising the profile. There was a real appetite to say medicines management is really complicated and complex. So is climate change, but actually there's a bit of a kind of win-win here. If we can kind of use the climate change lens to increase the importance of medicines management, raise the profile, get some investment in that, there's something good that comes out of that. The second one is, I'm going to have to turn around, sorry, forgive me, the starting point. So We're not starting at base zero. A lot of it is going on anyway. It's just around how we kind of scale that up. And the third one is around those drivers for change. And we can learn from the work. Can you hear me okay? We can learn from the work that we've done from the inhalers. We know some of those things that did actually escalate and implement change. Can't do it without people, stakeholders being you guys, you know, the wider community, but then also, you know, our patients and our public. There was a real theme around the resources and not set up to enable people to have those conversations. They're all over the place. We don't know which ones are good. So there's a real effort in how we focus those information and resources to make it really simple. When we're asking people to do this, they know where to go. And then we've got this change in culture and attitude, and that's where social prescribing might come in, non-clinical interventions come in, but actually engaging the patients and the public. So they were the themes. What I took away as my learning and insight, there was a really high engagement and an appetite for this subject. This was a bit of an experiment. People might have come and said, oh, you know what, we're worrying about finances in NHS Wales, we don't really care about this. But actually there's not. There was an awful lot of enthusiasm in MG, about 37 people that joined us. There was a recognition this is complicated, so we need to make it simple. We were challenged about being more ambitious. And actually, if we're going to do it, and we're going to do it quickly, and we need to not waste any time, we need to be ambitious about what we're going to do. Somebody said, basically, sustainable medicines management is just about better care. So, you know, there's a win-win for everybody. Most of the solutions already exist, we're just not doing it consistently and uniformly. But we do need to identify priorities, but priorities that link with NHS Wales priorities. So we're not asking people to do extra. So there's some work around that, and that's where that triple bottom line comes in that Nuala mentioned. A big piece of work around medicines resilience. We talked about inhalers being in cars and how we store medicines. I don't know anybody, I had something off the MHRA the other day just landing in my home inbox saying if you're on a statin, be careful where you store it. So there's a lot of work there around medicines resilience, but also the, you know, the supply of medicines and things like that. And there's work going on across Wales, not with us, but around that. And we identified enablers and barriers, which then gives us something to work on. So, talked about the good practice. You will hopefully recognise some of this. So, prescribing and waste came through. We've done lots of work around inhalers, polypharmacy reviews, still the best thing we can do. Great guidance already out there through AWTTC. We just need to kind of see that through a different lens. Antimicrobial stewardship came up. And actually, Meryl's in the audience today, and I know Meryl's got a workshop later, but we've hooked up and we're doing some work with Meryl over that. And then medicines waste reduction. How do we actually stop all that waste being incinerated currently? Non-drug interventions seem to be a clear winner there. Social prescribing, lifestyle support and self-care. Patient engagement came through really strongly as things that's already going on. We've got the Only Order What You Need campaign now that's been rolled out across Wales. We've got the Your Medicine, Your Health campaign that's been around for a long time with new web pages being developed. And how this all fits into shared decision making. Digital enabling is going to be an absolute winner for us. I sat next to Steve Short, I think his name is, who is a GP at Allpag that is doing a lot of the EPS work. And I kind of said to him, I hope you're measuring the carbon footprint of the work. And he said, oh, actually, I think we are, but maybe we need to be a bit more explicit about that. So some of these things are happening anyway, but we're not recognising the benefit, or what I call the co-benefit, that it's having. So we're doing a lot. We just need to kind of bring it all together. And of course, there are already resources and guidance available. There's a lot of information, the medicine optimisation work that AWTC already do, but it's written through a very clinical lens. It doesn't kind of have that just the so what. So maybe there's some work that we could do there. Okay. So, finally, what we want is to take this little fragmented, great, brilliant pieces of work. I haven't had a chance to look at the post-its, and I'm sure every single one of them is a project we could look at, and make it into a coordinated approach. That was our mindset with the inhaler work. That's where we started. And I kind of think that model worked. So there is something about shifting from that to something more coordinated. We want to develop a national vision. So each recommendation here has a whole half a page of things that could do to deliver that. The national vision to be done collaboratively, based on the triple bottom line, And then the key narrative, so we're all using the same language. The second one is to look at what's available. Somebody talked about carbon footprinting and your medical students training. Actually, some of the carbon footprint models are not great. They're not that robust. You get different outcomes depending on what you're using. But let's see what is available internationally and let's agree on one way forward. We can then identify high impact areas. Prevention, I need to say no more, but actually de-prescribing hasn't been mentioned today yet. So this is more than just prescribing. This is actually taking people off things they no longer need. And polypharmacy reviews is a way to do that. Scaling up the good practice. What do we know that's going on? What can we learn from? I'd love to have a case study from each health board. I spoke recently to Howell Dhar Health Board, who asked me a question that I couldn't answer around have we got some sort of criteria or framework for formulary decisions. So that's a really good example of something we could work through, but I don't know yet. We're trying to find one, but that might be something that Howell Dhar might be looking at. We then need to make sure that we don't increase inequalities. Now, I'm not an expert on the inequalities, but I've got people in my division who are. They tell me individual interventions have a huge risk of increasing inequalities, particularly when you're doing them in certain populations. So we just need to be careful we don't inadvertently cause more problems down the line. We need to support patients around waste. There needs to be work around understanding their behaviours. We need to have a scheme in Wales where people can recycle their medicines consistently via certain routes. And we're working on that with shared services, and there's a new contract coming up. We need to build capacity. We need to signpost to learning that's already there and make sure that people have that broad understanding, but actually make it really simple and easy and relevant to their work. And then we need to plan for what happens when the weather's terrible and we can't get hold of medicines or the medicines we've got fall over. So that's the recommendations. I have the privilege of going to the All Wales Medicine Strategy Group next week to present a 30-page report that I'll probably be criticised for if there's any AWMSG members here, because public health like to write long reports, but I don't apologise because there's a lot in there and it came from the people at that event. And what happens next will depend on the discussion at AWMSG. We're very invested in it. We are a very small team. We can provide a little bit of leadership. What we can't do is do it on our own. So I suspect there'll be a collaborative working definitely with AWTTC because it seems to sit very well with them and embed this into a lot of the national priorities that are going on. That's it in a nutshell. Thank you very much.